Good morning. Let's go ahead and get started with grand rounds this morning. It's my pleasure to introduce Dr. Pedro Pablo Gomez, or as we say, PPG. Dr. Gomez grew up in Colombia, did the combined 6-year medical school and college there, and then there's mandatory servitude, the draft, as we would call it here, which is normally a year. You can spend 12 months in a big city, 6 months out in the jungle, or 3 months with the rebels. He gambled and went 3 months with the rebels, and he loved it so much that he stayed for almost a year, like the Stockholm Syndrome from Patty Hearst, I guess. And then he came here and joined us during our residency. He spent 2 years in the lab. And this morning, he's talking about neuroendocrine tumors of the GI tract. Dr. Gomez.
Thank you. Took me 7 years to figure out where to turn off that light. I put on quotes carcinoid because, as we will discuss, they should be actually called neuroendocrine tumors. So I just want to start with 3 surgical vignettes, especially for the juniors, interns, PGY2s. These questions you can see very often on question banks. First one is a 60-year-old male, well, white male, comes 3-4 years with non-specific abdominal pain, diarrhea, flushing. Wife has noticed that this gets worse when he gets stressed or when he drinks, especially wine, chocolate, or bananas. This is usually the typical surgical vignette that makes you think of carcinoid syndrome. Second case, 55-year-old Afro-American male that comes to the ER with a bowel obstruction, hasn't had any operations in the past, doesn't have hernias. You take him to the OR after he fails to resolve with non-operative management, and you find significant desmoplastic reaction and lymphadenopathy. You do a segmental bowel resection, patient that's fine and goes home on day number 5. Or the last patient that I'm familiar with, 29 male, Hispanic, healthy, goes to the ER with 2 episodes of GA bleeding within the past 24 hours. After workup, he's found to have 3 polypoid lesions on the small bowel after his bowel resection. So just want to show the wide array of presentations that these, quotes, carcinoid tumors can have in different sectors of the population, race, sex, independently of where you are. I want to clarify that carcinoid tumors and carcinoid syndrome are completely different. Carcinoid tumors actually should be referred now as neuroendocrine tumors. And as a reminder, just 0.5% of all cancers or malignancies correspond to carcinoid tumors. So carcinoid should be coined or termed for those specific tumors that produce serotonin and are associated with carcinoid syndrome, which, as we will discuss, mostly are the ones derived from your midgut, or basically your small bowel carcinoids. And then the remaining, again quotes, carcinoid tumors should be termed neuroendocrine tumors instead of carcinoid. So historically, in 1888 was the first description of carcinoids as we know them. I believe this was in Germany by Lobarsch when he did autopsy into patients and found multiple tumors on the distal ileum. But then as you go chronologically, the term carcinoid was actually first coined in Germany in 1907 for tumors that look like cancer but were not specifically cancer. Over the past little bit of 50 years, different symptoms as well as findings have been associated with carcinoid, such as diarrhea and wheezing, the presence of enterochromaffin cells, serotonin, and most recently in '68, William and Sandler termed the embryologic classification for carcinoid tumors as being foregut, midgut, and hindgut, which will be the way I will divide this presentation. So again, this classification is based on the embryologic origin as well as the arterial blood supply to the different parts of your GI tract. So for your foregut, you have your stomach, duodenum, pancreas, midgut, mostly your small bowel, appendix, and right colon, and the hindgut, the transverse colon, descending colon, and rectum. In the chemistry of carcinoids, it is important to recognize that serotonin plays a key role, and then its main precursor, the amino acid tryptophan, suffers two series of chemical reaction, hydroxylation and decarboxylation, I guess you pronounce it, where finally it's transformed to serotonin, and then serotonin is breakdown in the urine and produces the 5-HIAA that most of us are familiar with when talking about carcinoid. One thing that I want to point is that foregut carcinoids lack the enzyme that produces the decarboxylation that converts the hydroxytryptophan to serotonin. So these tumors will have low levels of serotonin, and actually, as I will discuss later, often secrete different markers, mainly histamine. The main cell for carcinoid or neuroendocrine tumors has received 3 different names depending on where you read. It can be named the enterochromaffin cell or enteroendocrine cell, or if you go back in history, also known as the Kulczycki cells, which is the most common histopathologic type of carcinoid cell. These type of cells actually stain to silver. That's what they're calling argentaffin. In most of the times, they will stain because of their serotonin production as well as other granules that they make. One thing that I also want to point about carcinoids is that these type of tumors usually invade the submucosa and then start extending outward until they compromise the muscularis propria as well as the mesentery and the lymph nodes. In a nutshell, I just want to mention again that only the midgut carcinoids will have these argentaffin positive properties, reason why their levels of serotonin will be elevated as compared to your foregut and hindgut carcinoids, which actually will rarely have increased levels of serotonin. So there's many different substances that are synthesized by your gastrointestinal neuroendocrine tumors. There's a wide list in here, going from your neuron-specific kenolase, your serotonin, your hydroxytryptophan, chromograninate, growth factors, and a lot of these substances are actually used as tumor markers that can identify, diagnose, and survey this type of neuroendocrine tumors. The World Health Organization has classified in 3 different opportunities carcinoid tumors, first in 1980, then in 2000, and most recently in 2010, trying to have a consensus of how pathologically these type of tumors need to be classified, going with the most recent classification as neuroendocrine tumors grade 1 and grade 2, and neuroendocrine carcinoma, which is basically your grade 3. In regards to the frequency of carcinoid tumors, 2.5 to 5 people over 100,000 suffer this disease. Widely common in the GI tract, almost 70%, mostly in your small bowel, followed by your rectum and then by your stomach. And the second most common site outside the GI tract will be the bronchopulmonary tract. Interestingly, there is no clear environmental risk factors associated with carcinoid or neuroendocrine tumors. Recently, there was a review of the incidence and prevalence of carcinoids with the SEER database that actually reviewed from 1970 to 2005 multiple records of patients with this diagnosis, and the incidence and prevalence has been noted to significantly have increased over the past few decades. Partly when I have reviewed this topic seems because we have better screening, we're doing more EGDs, more colonoscopies, thus the reason to have this diagnosis more commonly during our population. Actually, in the time that I've been training here, I never thought that I was going to have patients with this, and I think I have 10 or 15 over the past 7 years that I've been here, which I think is quite remarkable. Now, going by the different types of carcinoids or by the embryologic origin. My goal at this point of the talk is just to focus on the different types of tumors that we have, how to approach them, how to treat them, and make it easy for you guys. So hopefully when you get a consult or see a patient like this in the ER or in the wards, you can have an algorithm that you can follow. So esophageal carcinoids, really rare. Actually, you mostly find this information through case reports. Interestingly, they're mostly localized in the distal portion of the esophagus. Patients usually present with dysphagia. They're found a lot of times incidentally during an EGD for dysphagia. And when you go back in history and you check the early reports, they used to be treated extremely aggressively with an esophageal gastrectomy, sometimes even with a subtotal esophagectomy with a gastroesophageal anastomosis. But actually in Japan, where they seem to be more common, there's new techniques, as you can see on the right bottom picture, such as endoscopic mucosal resection, specifically for those tumors that are less than 1 to 2 centimeters. Again, really rare, but I think it's worth mentioning. Now, gastric carcinoids. Actually, I've seen a couple here at UH. They just represent 1% of the gastric neoplasm and 4% of your GI neuroendocrine tumors. Depends on where you read. It can be classified from 1 to 3 or actually 1 to 4. What matters is types 1, 2, and 3 are derived from the enterochromaffin cells, and type 1 and 2 are actually related or gastro-independent. So breaking them down, type 1 gastric carcinoids is the most common type of gastric carcinoid, almost 80% of the population. Interestingly, is the trophic effect of gastrin over the enterochromaffin cells that actually creates hyperplasia of these cells, and that's why these patients often presents with multiple tumors, more specifically, actually more commonly in the antrum, and they're highly associated with autoimmune conditions such as pernicious anemia, trophic gastritis, as most autoimmune diseases are more commonly found in women, young women less than 50, usually less than 2 centimeters. They're widely benign, and your approach, basically, if they're small tumors less than 1 centimeter, a lot of GI doctors opt for endoscopic removal, and those are larger than 2 centimeters. Surgical excision is recommended, more specifically entrectomy, given the fact that these are associated with hypergastrinemia, basically to reduce the effect of gastrin in the enterochromaffin cells. 5-year survival is great, 98%. What about type 2? These are actually the third most common gastric carcinoid. Same as type 1, they're gastro-independent. Interestingly, they're associated with Zollinger-Ellison syndrome, as well as MEN1. As mentioned before, they are gastrin-dependent. Males and females suffer basically the same frequency of these type of tumors, multifocal as well as type 1. They have greater malignant potential than type 1, but still remain quite benign. And the treatment actually should be focused at removing the source of your hypergastrinemia. In this case, if it's a Zollinger-Ellison syndrome, that should be addressed at the same time you're excising this carcinoid. Similarly than type 1, those that are less than 1 centimeter, endoscopic removal is recommended. Those larger than 2 centimeters, surgical excision by the form of an entrectomy or gastrectomy is suggested as well, and also have a great 5-year survival, almost of 90%. Now, type 3, these are the ones that are tricky. They're not gastro-independent. This is the second most common type of gastric carcinoids. Usually they're solitary lesions. They used to be a little bit larger, more than 2 centimeters, more frequent in men over 50 years. But unfortunately, they're associated with regional lymph node involvement as well as liver metastases. The term here, atypical carcinoid syndrome, which happens in 5 to 10% of patients is because of the fact, as I explained before, this type of tumors do not have the enzyme that converts to serotonin. So actually, in this type of patients, the flushing, the diarrhea, the bronchospasm is thought to be caused by histamine and not by serotonin, as it typically happens in patients with carcinoid. They are treated actually in a very similar fashion as gastric adenocarcinoma with an en-bloc resection and then extensive lymphadenectomy, D1 versus D2, depending on the involvement. 5-year survival is less than for type 1 and 2, 50%, and unfortunately, when metastatic disease is present, this goes down to 10%. As I mentioned before, type 4, not all books or articles agree that they should be labeled as type 4, but basically these are mixed tumors. By the time they present, they're surgically unresectable, very poor prognosis. People last less than a year, and the treatment that is suggested for these type of patients is basically chemotherapy. Reviewing or studying for the boards right now, I found something interesting. Typically, when you talk about MEN syndromes, you'll always think of the PPPs, right? The pituitary, pancreatic, parathyroid. But there's a wide array of conditions that actually are related to MEN1, including foregut carcinoid. So I just wanted to bring that to your attention. And since we're mentioning MEN1 syndrome, I actually found that one of the indications to screen for MEN syndromes is people that had foregut carcinoids in the bronchial or thymic area, which are not a matter of discussion during my presentation, but I think it's important to note. This is basically an algorithm that summarizes what we just discussed: less than 1 centimeter, endoscopically remove, more than 2 centimeters, resect, and if you have type 3, basically treat as if it was gastric adenocarcinoma with resection and lymphadenectomy. Not going to go over details about the NCCN guidelines, but I think for all residents, and as well as if you're a faculty interested in this type of topic, you can go for free online through your iPhone or through your iPad. I also believe through Android system. You just need to register for free. You can download all the guidelines for basically every single tumor that we can actually operate or not operate. And you can follow this very complex algorithm and can be very useful in the clinic or treating for patients with oncologic disease. Now, duodenal carcinoids, also part of your foregut carcinoids. Usually, they will affect the first and second portion of the duodenum, most likely in the periampullary region, more common in males, Afro-Americans. As most carcinoids, they will affect people in the 5th and 6th decades of their lives. And then symptomatically, they will present with obstruction or obstructive jaundice and symptoms related to local growth. Survival is actually quite good, 84%. And of the 3 histologic types, the most frequent one is the one related to gastric cell tumors, just as type 1 and type 2 gastric carcinoids. And treatment will depend on the size and location, but basically those that are small and can be locally excised through a transduodenal approach, that's an option. But if then they are significantly extensive, these patients will require a Whipple or a pancreatic duodenectomy. Again, these are the NCCN guidelines for those of you interested in going into more depth for this topic. Now, midgut carcinoids, which is, I think, the meat of my talk, because they're very frequent. The most common location by far of all your neuroendocrine tumors, and these are the tumors that actually should be called carcinoid tumors. They happen anywhere on your small bowel, but they will increase in frequency as you go distally. The most common location is the terminal ileum, and I find this very interesting because I remember when I was in med school, 2001, and one of these tests asked which was the most common location for carcinoid tumors. The answer then was the appendix, but as I mentioned before, after the SEER database was published, actually, the terminal ileum seems to be the most likely location for carcinoid tumors, as far as I can tell. It's very important to recognize that a third of patients that have midgut carcinoids will develop carcinoid syndrome, and this, independently of the size, can have metastatic or spread regional or distant. They will originate from malignant transformation of your enterochromaffin cells. As mentioned before, they will originate on the submucosa of your GI tract. Metastatic spread is most common that with your gastric and duodenal carcinoids. And a fact that I think is key for especially all residents is most patients will have a single lesion, approximately 2.5 centimeters, but it's very important to recognize that a third of the patients will have multicentric disease. So if you are doing a laparotomy or a hand-assisted laparoscopic bowel resection, it's extremely important to run the bowel, because you can have lesions within a few inches of your GI tract, of your small bowel, or actually quite distant. Small bowel carcinoids, one thing that is key is that size really doesn't matter. As you can see on this picture, that is barely a 1 centimeter lesion that actually has quite the desmoplastic reaction and and compromise of your lymph nodes. So size is not an indicator for your metastatic potential. Most people will present in their 5th to 6th decades of life, non-specific abdominal pain. Some people will present, as I mentioned in the surgical vignette, initially as bowel obstruction. About a third of patients will present with your carcinoid syndrome, and rarely they will present as GI bleeding. What about tumor markers for this type of disease? So there are specific markers, such as your 5-HIAA, which, as mentioned before, is the final breakdown product of serotonin. It's extremely important to tell patients that you need a 24-hour urine collection and not a random sample. And it's actually quite specific, almost reaching 100% on specificity to diagnose carcinoid tumors. Not that frequently, but you can also measure your platelet serotonin levels. And for patients with gastric carcinoid, histamine instead of serotonin, as mentioned before, should be measured with their breakdown products of histamine as well in urine. Non-specific markers, chromogranin A, not specific for carcinoids, but when the levels of your chromogranin A are elevated, basically correlates with your tumor mass or tumor load. Your neuron-specific enolase, again, not specific for carcinoid tumors, but once it's present and is elevated, is associated with poor tumor differentiation. What about imaging modalities? What can we do? CT scans, MRIs, very sensitive, almost roughly the same, about 80%. You can see here on this picture the typical spoke and wheel pattern that is seen after a patient has mesenteric involvement. Most commonly, your octreotide scan, which all patients with carcinoid tumors should get, has a positive predictive value of 100%, complements your CT scan or MRI in regards to the anatomical location or distant metastasis of this type of tumor. And most recently, actually, you can get PET scans with radiolabeled serotonin, which actually can locate really small tumors, as you can see here, where the picture shows a duodenal carcinoid after doing this test. Now, carcinoid syndrome. So carcinoid syndrome, again, is different than carcinoid tumors. Basically, it's a constellation of symptoms from the massive release of the multiple substances that these type of tumors can produce. Serotonin being the most frequent, but again, as mentioned before, with gastric carcinoid, histamine could also be responsible. The most common symptom and what annoys patients the most is flushing, almost in 94% of patients, diarrhea in 80%, bronchospasm, abdominal pain, pellagra, which is your niacin deficiency, because tryptophan is actually your precursor for niacin, and carcinoid heart disease, which affects the right side of the heart. When does carcinoid happen? So usually this will happen once you have liver metastases, but not necessarily the lack of liver metastases means that you cannot get a carcinoid syndrome. When people have retroperitoneal disease, when the tumor burden is significant, or patients with liver dysfunction could actually also have carcinoid syndrome. It's also important to recognize that on imaging studies, about 15% of the time, this imaging fails to reveal liver metastases because of the small size or the miliary pattern of carcinoid tumors. Unfortunately, the therapy, which is serotonin receptor antagonist, typically doesn't have that of a good effect on this type of symptoms. And if it works in less than 50% of patients for less than a year. So extremely annoying consequence of carcinoid tumors. So how do we treat the small bowel carcinoid? So resection of the tumor and the nodes is pretty much the keystone of management of these midgut carcinoids. What about mesenteric nodal disease? Why are we doing that? Number one, because it increases survival. What about patients that have hepatic metastasis? Should we go and remove the primary? The answer is yes, because actually by removing the primary, it will deprive the liver from all the substances that are released into your circulation, and actually it is related with better progression-free survival for this patient. And once patients present with hepatic metastasis, you could go resection if the patient is a good candidate, or ablation, which again has shown an increase in your survival. So multiple ways of addressing these hepatic metastases. As you can see on the right upper picture, on an MRI, large, big liver metastasis for a patient that has a carcinoid tumor with a carcinoid syndrome, but as well on the right lower picture, really tiny metastasis, the miliary pattern. So you can do hepatic embolization, many techniques. You can use particles, microspheres, gel foam. 50 to 80% of patients respond, or also you can mix substances such as doxorubicin or cisplatin or streptozotocin, but none of those techniques have shown to be superior over the other. What about medical therapy, which is, I think, the cornerstone once you get metastatic disease? Basically, only two therapies are available, both of those somatostatin analogs, sandostatin and lanreotide, mostly for symptomatic therapy, sometimes for palliation, especially in patients with carcinoid syndrome. As mentioned before, the relief of symptoms happen 50% of the times to 75%. The biochemical response, the actual decrease of the substances, serotonin, histamine, and the long list I mentioned before, happens in half of the patients. Different than when you use Gleevec for GIST, tumor response with somatostatin analogs for carcinoid, rarely seen, unfortunately. But patients report that symptomatically they do better, and as mentioned before, unfortunately, patients get tachyphylaxis a little bit over a year, so just 12 months of therapy. So what else can be used? Interferon has been suggested as one of the therapies that can manage or address your carcinoid syndrome symptoms, but when you go over the literature, there's reports that go from 8% to 70%, depends on where you read. And there's, again, cytotoxic therapies, but unfortunately, duration of relief of symptoms lasts barely half a year. What about chemo? Should these tumors have chemo? When you go by the NCCN guidelines, sometimes chemotherapy is suggested or recommended, but unfortunately, two recent randomized trials with the use of 5-FU and streptozotocin again shows poor response, 33% to 22%, really without evidence of improved survival for carcinoid tumors. Radiation. Can we use radiation? Patients who have bone metastases, which are painful, external beam radiation is something that has been suggested. Most recently, radio-labeled MIBG can actually have an effect on symptoms, a little bit more than 50%, as well as tumor and biochemical response, but really low, 15%. And then, as mentioned before, your somatostatin analogs are part, when combined with radiotherapy, sometimes they're recommended for palliation as well. So what is the prognosis of patients with midgut carcinoids? Well, that is stage dependent. There's the TNM classification, which I did not include on my talk, but basically for people who have localized disease, 5 and 10-year survival will be 73 and 65% respectively. So a little bit worse than gastric and duodenal carcinoids, but it's still fairly good. And for those patients with distant disease, distant metastasis, your 5-year survival will be 54% versus 30% after 10 years. Patients that have increased risk of mortality include, of course, those that have distant metastases, the ones that have carcinoid syndrome, females, and pathologically, those that have a Ki-67 index more than 1% or a solid growth pattern. Again, this is an algorithm that summarizes the recommendations that we just discussed. And then for those that want to go on a more detailed information, you can get the NCCN guidelines. Now, appendiceal carcinoids, which is one of the topics that is most commonly brought in different, in the AppSide board certification. Appendiceal carcinoid is the most common neoplasm of the appendix. Most of the times this is found incidentally when appendectomy is done because of suspicion of appendicitis, or in the female or in women because it was part of diagnostic laparoscopy. Size in this case, as different than your midgut carcinoids, will be predictive of their metastatic potential. How to approach them? Those that are less than 1 centimeter, which are mostly at the tip and is the vast majority of appendiceal carcinoids, are well treated with an appendectomy. Now, those are more than 2 centimeters. A right hemicolectomy is actually suggested, given the fact that they metastasize to your lymph nodes. And then those between 1 to 2 centimeters should be, your treatment should be individualized. So if you go to this table, again, we said more than 2 centimeters, basically you do a right hemicolectomy. But then those that are between 1 to 2 centimeters is suggested to actually perform a right hemicolectomy if your mesoappendix is compromised, if there's lymphovascular invasion, if your margins are involved, if your Ki-67 index is more than 67%. But one of the rare variants, the goblet cell variant, which is actually your adenocarcinoid, is quite a rare variant of your appendiceal carcinoids. Are very aggressive with extremely poor survival. 10-year survival is 60%. And again, regardless of size, this is the only time size doesn't matter, all these patients will need a right hemicolectomy. And again, a summary of the recommendations based on size and right hemicolectomy, as we just discussed, NCCN guidelines for those that want to download the app, and then hindgut carcinoids. So what about carcinoids that go to your colon? Most of the colonic carcinoids will happen in the right side, since the right side is part of your midgut, and this is the most common location for carcinoid tumors. As patients with colonic adenocarcinoma, they tend to be large in size. They have a lot of space to grow. They're poorly differentiated, have metastatic disease, usually by the time they present, and they rarely secrete serotonin, which is similar as what happened to your foregut carcinoids. And those that happens on the rest of the colon, similarly, they will be large, more than 5 centimeters, will be exophytic lesions, and then the main recommendation for treatment will be radical resection with lymph node clearance. 5-year survival actually, unfortunately, is slightly worse than colorectal adenocarcinoma, being roughly 40%. And then rectal carcinoids, which is the second most common site for your GI neuroendocrine tumors. I've seen actually a couple here at UH. They have a benign profile. They usually present, again, in the 5th to 6th decades of your life, more commonly in African Americans, and usually it's an incidental finding during a screening colonoscopy. You see this polyp, you take a biopsy, and that's usually the way they're diagnosed. But when symptoms are present, patients will present with weight loss, constipation, nonspecific GI complaints such as changes in your bowel habits, including diarrhea. Your 5-HIAA and your chromogranin A will be rarely elevated for these patients. And the approach is very similar to your gastric carcinoid. So if they're less than 1 centimeter, and with the technology we have, you can do an endoscopic excision, as you can see on the pictures on the right. Those are in between 1 to 2 centimeters. Endoscopic ultrasound or MRI is recommended. If the muscularis is not compromised, then a transanal excision can be attempted. But for those that are compromising the muscularis, is the same recommendations as for those that are more than 2 centimeters, which is a total mesorectal excision via LAR or APR, depending on your location. Again, survival, since these type of tumors are the most benign, 87% at 5 years for those with localized disease, and unfortunately 25% for those with distant disease. And again, your basic algorithms to follow the therapeutic approach. How to surveil, what about the surveillance of this type of tumors? When you go by the NCCN guidelines, 3 months to a year after resection, and I like how they write the word consider. So based, if you had a foregut, midgut, or hindgut carcinoid, it's recommended to get some biochemical markers. It will, again, change depending on the anatomical location. Getting abdomen, pelvis, CT scan versus MRI every 3, 6, 12 months, especially in the first year, is something that will be ordered based on your oncologist, and chest CT for those that had a thymic or a lung carcinoid. And then there should be over a year to up to 10 years, basically the same recommendations, HMP, biochemical markers, and CT scans of your abdomen, chest, pelvis, based on the anatomical location of the tumors. Not going to go into a lot of detail for this part, but again, for people that have recurrent disease, I just want to point this part of the NCCN guidelines, which is if these carcinoids come back and you can resect them, even if they have metastatic disease, go for it. The other different recommendations for chemo, radio, all this stuff, I will leave for another talk. And then the last thing that I want to mention, that actually I was not aware before preparing this talk, is carcinoid crisis. So for those of us taking patients with carcinoid tumors or neuroendocrine tumors or people with carcinoid syndrome that we know beforehand when we're going to take them to the OR, it is important to discuss with anesthesia that actually during induction, while using an anesthetic or as we manipulate the bowel in the OR, This patient can have this carcinoid crisis, which will manifest as profound flushing. They're going to have hypotension being more common. They can have tachyarrhythmias in the monitor. Their glucose might be high. They can have bronchospasm that might be refractory to the beta-2 agonist that anesthesia gives. There's actually a protocol that I wrote here with octreotide of how to do it pre-op, intra-op, and post-op. But I think one thing that is key, and I don't know if there's any anesthesia interns here, is when these patients present and have hypotension by reflex, anesthesia will start them on norepinephrine drip, phenylephrine, epinephrine, which actually can exacerbate the hypotension because this actually will increase the serotonin in the circulation. So again, the recommendations for this carcinoid crisis, which again is different than your carcinoid syndrome, is resuscitation with IV fluids and octreotide, as in the protocol that I have that I mentioned here, and then glucocorticoids is another ancillary treatment for this type of presentation. This basically concludes my talk under time for my grand rounds. I want to share with you, every single morning when I walk through UH, right there by the Starbucks coffee, as well as in the waiting room on the second floor of the OR, there's this quote, I really like it, which says, "Wherever the art of medicine is loved, there is also a love of humanity." Does anyone know who is that quote from? Yes, sir, the guy is right here. That's what most people don't see. You see his eyes, beard, right there in the picture. I also want to take the opportunity to, sir? I don't think any heard you. It was in the back. Oh, yes, so you can see Hippocrates is here, actually in the back of the picture. You see his eyes, nose, beard. You can really need to take a look, but he's always there watching you. Like, one thing that I want to share, this presentation is very, very personal to me. This is not a HIPAA violation since I'm the patient, I guess. But 2011, I got a carcinoid, and I think it was the scariest time of my life. Especially remember Dr. Stewart. I was the third guy on that surgical vignette with the obscure GI bleeding. I remember Dr. Stewart stopping by, and I was a PGY2, July, brand new PGY2. And when you ask your chairman what's going on with me, and your chairman tells you, I don't know, PPG, I don't know. That's pretty scary, number one. Actually, it was mine. Number two, it was actually I think the best time of my residency at the same time, because I truly appreciated the work of the many residents, faculty, nurses, and all the health personnel that took care of me. I don't think we realize how much we can impact someone just by stopping by, saying hi, or taking care as doctors. So I appreciate that a lot. I think gave me a different perspective as a doctor, as a surgeon in training. So I highly encourage all of you to take care of each other, because you can be patients anytime. And I think most importantly from that time, I was my wife now. We were dating maybe for a couple of months. And I realized at that time that she was the woman I wanted to marry, because if she liked me and she found me barely attractive with, I don't know, a hemoglobin of 6.7, walking butt naked in the hallways with a room that was stinking of melina, if she passed the test, so that's how I knew. So I'm not suggesting to get sick to find the love of your life, but I think it helps significantly. And with that, I want to finish my presentation. Hopefully, it was not a information overload, and I'll take any questions. Thank you.
dating service.
Yes.
Having to do with sick patients. Picked up by a nurse.
It is true. She was not, just to clarify, she was not my treating nurse. There was no,
I can understand that.
yes, just clarify.
One of the things that you didn't mention with the syndrome is that it's got to be, beyond the liver or in the liver, right?
Correct.
One of the places, obviously, and they ask it all the time on tests, are the lungs.
Mm-hmm.
If you have the carcinoid in the lungs.
Yes, so if I didn't include bronchial carcinoid in my presentation, but people that present with bronchial or pulmonary carcinoid, since they're bypassing already the liver, they can have significant bronchospasm as well as some flushing because of the release of serotonin and other substances into the circulation. Mm-hmm.
Did you come across where we found Mets but could never find the primary? The reason I bring it up is I've had two patients that we were going to do a lap chole on, and we put the camera in, and then there are these spots all over the peritoneum and all over the diaphragm that turn out to be carcinoid. And we worked up both of those patients from head to toe and could never find the primary.
Yeah,
The patient, thank God, has successfully responded to octreotide. I was surprised to hear because these patients now have been on octreotide longer than a year and they have not developed tachyphylaxis.
good, that's good.
Any questions?
Yes, sir.
The place where we encounter them most commonly on our services, incidentally, and I've had probably 3 or 4 in the last couple of years that were found, not even recognized at the time of surgery, but
later.
The path report on an appendectomy comes back. They found carcinoid. And I've noticed that in our path reports here, they don't mention a proliferation index or anything like that. They normally grade them as low, intermediate, or high grade neuroendocrine tumor. How is that low? Should I be asking for a proliferation index when we get that back?
So actually, interestingly, they seem to be using the WHO 2000 classification instead of 2010. It seems so because the cases I had here, as my case, actually that's the way it was reported. I think what ultimately matters based on, because we're talking about midgut carcinoids, more than size is the compromise beyond your submucosa, see if the patient has carcinoid syndromes, and ultimately doing more workup, your octreotide scan, maybe a PET scan, getting chromogranin levels, getting your 5H IAA, and have a good consultation with medical oncology, which are way far more updated in guidelines and pathological diagnosis. A lot of times they actually re-review the slides. I had a couple of patients that we were not satisfied with the results, and we asked them to review again the slides, and that's something that I think we can do specifically here at UH.
But I guess specifically for HINDGUT, because that's what I'm asking, is this grade affect prognosis screening? In other words, if you have a 1 centimeter HINDGUT carcinoid that's low grade, you would say that appendectomy alone is sufficient. What if that's the same thing but it's a high grade, a 1 centimeter high grade HINDGUT?
As far as I can tell from the review that I did, grade was not an indication for hemicolectomy, just the different items that I mentioned, if it's invading the lymph nodes, if it's spreading around, if it's proximal positive margins, Ki-67, which I rarely see reported here. And those patients, I think, will need to be presented on a tumor board and see what's the consensus out of that.
The other one that you didn't mention too is patients on long-term PPI therapy will develop carcinoids. Yes, Dr. Cruz.
That was the most masterful presentation in subject matter.
Thank you, sir.
You had it covered all over, on the table, off the table, figuratively and literally.
It's not a requirement to present a grand rounds, though.
That really fascinates me with subject matter, and if you heard our discussion with the itunes. And that, sometimes this disease presents itself like a a disease that has cell rest all over, just waiting